Chris, just one question, sorry. We do need closed captioning.
Yeah, that'll start with the transcription.
Okay. Good afternoon, everyone. Thank you for joining us for today's genetic webinar entitled Understanding Developmental Delay and Disabilities. This series is jointly provided by Texas Children's Hospital in collaboration with Baylor College of Medicine, Texas Health and Human Services, and the University of Texas at Austin, Texas Center for Disability Studies. Support for this presentation comes from the Department of State Health Services. Just a couple of accreditation and disclaimers here. The nursing accreditation and disclaimer slide is being displayed currently, and you can also interact with the presentation slides today, so feel free to click on those. If you are a social worker, licensed professional counselor, licensed marriage and family therapist, and licensed psychologist and would like a free 1-hour CEU, this webinar has been approved for 1 hour by the University of Texas at Austin Office of Professional Development, School of Social Work. The views and opinions expressed during this presentation do not necessarily reflect those of the School of Social Work or the University of Texas, nor does the mention of trade names, commercial practices, or organizations imply endorsement by the school or university. We'll be sharing how to receive your CEUs for social work and nursing at the end of the presentation. We will be saving time for your questions at the end of today's presentation, but you can submit your questions at any time during the presentation using the Q&A box at the bottom of your screen or top of your screen. Today's presenters are Dr. Holly Harris and Laura Buckner. Dr. Harris is committed to providing family-centered and evidence-based care for children with neurodevelopment challenges. She enjoys discovering each child's unique strengths while also aiding the patient and family in navigating any challenges or uncertainty that may accompany a neurodevelopmental diagnosis. Along with providing diagnostic evaluations and ongoing care if needed, she additionally invested in research seeking to broaden our understanding of these diagnoses in order to best care for patients. She sees patients for diagnostic assessment at the Mayer Center for Developmental Pediatrics and Autism, and serves as director of the Fragile X Clinic at the Mayer Center. Laura holds bachelor's, master's degrees in education, counseling, and rehabilitation. She is a licensed professional counselor and a certified mentor trainer in person-centered practices, the learning community for certain person-centered practices. Laura's experience in educating others about family supports, state, local, and federal community resources for people with disabilities and their families, program development, and communication, sharing the success stories to impact change. As a family member herself, she specializes and especially appreciates opportunities to work with families and those who serve families. She says her most important degree is her MOM degree, her mom degree. Having parented her 35-year-old son, diagnosed at 3 months of age with a rare disease that includes IDD, autism, and chronic health issues. Laura says he has taught her everything she knows. Well, almost. So at this time, I would like to invite Holly to present her slides.
All right. Does everyone see the title slide?
Yes, we can see it.
Okay, perfect. Well, thank you so much for inviting me to speak today. This is a very big topic, so I'm going to narrow in on a few objectives for us in the short time that we have together, but of course we could talk about this for a while. My disclosures, I think we're on the first slide, but I am an author for Up to Date and have some industry and federal funding for various research projects and a training grant where we get to train more people to be experts in the field of neurodevelopment, and then some occasional consulting related to Fragile X. So as I mentioned, I'm going to focus on 3 things today. So I want us to understand developmental expectations in children 0 to 3 years of age, because we have to understand what's expected in order to recognize warning signs for developmental delay. Secondly, I want you all to be able to describe the appropriate medical evaluation for children 0 to 3 years of age with concerns for developmental delay. And then to recognize some key community resources for children 0 to 3 with concerns for developmental delay. So we'll start with that first objective. So what are our developmental expectations in those first 3 years? And I wanted to spend a minute on this because there has been a bit of a shift in the field as of 2022. So we determine when we're concerned about a delay based on milestones. And developmental milestones are things most children, so 75% or more of children, can do at certain ages. And like I mentioned, this is a shift in 2022. There was a landmark publication in Pediatrics where a group of content experts in the field kind of moved from the 50th percentile milestones to the 75th percentile with the goal of kind of avoiding that watch and wait approach. So if a child sees their pediatrician and is not meeting a milestone, the expectation is that we're referring immediately, at least for further evaluation, because if a child's not meeting that milestone, that means that the majority of other children their age are, and we should be concerned. So that's the reason for that shift. And so the milestones are a little bit different than prior years as of 2022. So I wanted to kind of look through each age and kind of think about what we would expect children to do. Plus, we get to look at very cute pictures along the way. So at 4 months, we're already expecting children to have a social smile, to look at you, and to be reacting to noises and sounds in their environments, and even starting to make a few sounds themselves. They're going to be watching others when they move around the room. In terms of the motor skills, they're able to now kind of hold their chest up on their forearms, and they're kind of swatting at toys and holding their head steady. We're not expecting any head lag at that point. At 6 months, children are laughing. They know who's familiar. They're making those raspberry sounds, and maybe even turn taking with their caregiver, grabbing for toys, putting things in their mouth, which is also good for us to think about as providers, not to leave things lying around. They're rolling in both directions and starting to sit, propping on their hands. So tripod sitting is leaning forward and propping on their hands. By 9 months, children are very aware of who's a stranger, and that kind of also correlates with that separation anxiety. So they're more attached to parents. They get distressed when separating from their parent. That's actually a good thing to see at this age. They're playing interactive games, also trying to communicate with their gestures, lifting their arms to be picked up, turning to their name. So at 9 months, children are already turning to their name specifically, and that's important to look for. They're looking for fallen objects. They have object permanence is the term we like to use in the field, but they know that, that thing didn't just go away. It fell down. I know how to look for it. They're transferring objects from hand to hand, and at this point, sitting unassisted. At 12 months, children are playing a little more complex games like pat a cake, waving, calling for mom and dad specifically. So by a year, they really should be using those terms for a parent, whatever that term may be that the family uses, and they should understand no. They're putting objects into containers, looking for hidden things. So you put a blanket over a toy, they know to pull it away and look for that toy. In the motor domain, there's a lot going on. They're pulling to stand, they're cruising, and in the fine motor domain, they have a pincer grasp, so able to pick up those small items with the thumb and their first finger. At 18 months, we're pointing to show things to our caregiver, helping with dressing, looking at a book with the caregiver, so kind of a lot more engagement, really at this point trying to say 3 or more words outside of names. So not just names of people, but 3 other words, and using those words in the day-to-day. So children can also follow directions without needing any gesture support at this age. You start to see children imitating what they're seeing their parent or caregiver doing around the home, playing with toys in a simple way as they should be. So pushing a car back and forth, And then at this point, we would expect 75% of children to be walking, taking steps on their own. And then using their fingers to feed themselves would be another skill we would expect by 18 months. At 2 years, children are kind of picking up on the emotions of others. So noticing if another is hurt, looking to you or a caregiver as to how to respond to a situation. They're able to start to point to things when you ask them to. Identifying pictures in a book, putting 2 words together, such as more milk, pointing to body parts like this little girl. That should be present around 2 years of age. They're starting to manipulate things like switches or knobs, play with more than one toy at a time. So putting food on a plate and kind of using multiple toys at once when they're playing. Children at 2 are able to run and kick a ball, use a spoon, and walk upstairs with or without help. So, with or without a rail or a parent's hand. And at 30 months, we expect children to play next to another child. It's okay if they're still doing their own thing, but next to the other child, but sometimes they may reach out to engage. They can follow some simple rules like cleaning up. There's a lot of look at me at this age. So you would expect your 2.5-year-old to really be seeking the attention of you, of others in the room. See what I can do, look at me. Saying about 50 words. That's the number of words you really need to start using those 2-word action sentences or phrases like doggy run or daddy go. They'll start to use pronouns like me, pick me up. And then cognitively, they're using things to pretend at this point, doing some pretend play. Can follow 2-step instructions and then starting to know things like colors. And then using their hands to twist things open, jumping with 2 feet off the ground, and starting to undress on their own. So here's some kiddos playing next to each other, jumping up with 2 feet off the ground and using a phone for pretend. And then at 3 years, they notice other children and actually may join in to play with them. They can go back and forth in a brief conversation, asking a lot of those WH questions. Who was that? Why? Where'd it go? And they can say their first name if someone asks. They can draw a circle. They know to avoid hot objects. And then the movement and physical domain, they may be stringing items together like beads, using a fork, actually piercing the food and able to bring it to their mouth, putting on some clothes independently and alternating their feet on the stairs. So here's some kiddos drawing. She's probably drawing a circle because she's 3 and then playing together in a sandbox. And so I wanted to kind of reorient us and remind us of those things that we would expect children to be doing at those ages. So what would be some red flags? So if you're working with a child, what would be red flags in each of these areas? So in the motor domain, I think about any asymmetry on our motor exam. So is anything different on the left than the right? So are things not moving together in the same way? So if you notice one side seems weaker or not moving as much, if a child has significantly low tone, so is very, loose, or sometimes we use the word floppy, kind of you pick them up and they just seem to, almost fall through your hands. On the opposite side, significantly high tone or stiffness would be concerning. Weakness, which is different than tone. So tone is kind of how their muscles are at baseline. Weakness is if you ask them to, push against you and they really can't give you any force. Feeding difficulties like choking or gagging make us concerned about oral motor coordination or also potentially low tone. And then if they have a clear hand preference before they're a year old, that's actually concerning because that would suggest to us that there's some asymmetry back to that first point. We wouldn't expect a child to only be using one hand before that time. And then, as I mentioned as we were going through normal development, a child who's not walking by 18 months, you would definitely want to refer that child on for further evaluation. Any hand wringing behavior, can be concerning, and then any regression in this area. So a child has clearly attained a skill and using it for several months and then stops walking. That would be quite concerning. In the area of communication, we're thinking about things like a lack of eye contact. We were mentioning they're already fixing on people as early as 4 months. And then as we progress through those slides before, they're starting to kind of look to others for their reaction. So if you're not seeing that, that's concerning. You want to see that social smile by 4 months of age. If you don't see that, that's something to keep an eye on. Lack of pointing or gestures by a year, a lack of a specific name for a primary caregiver by a year is concerning, and then a lack of response to their name. As I mentioned, they should be responding to their name by about 9 months old. So that would be concerning. And then, of course, if they're not responding to noise in general, even as early as 4 months, that could be a red flag. A lot of those things are early signs of autism, but or it could just be a delay in language or an auditory problem. And if a child really can't make their needs known, that's concerning. Regression, again, is concerning in this area. I have a little asterisk next to it because a lot of times there is a small portion of children with autism that will have a social or language regression that parents report to us. We're pretty strict on our definition in that a child really needs to have 5 to 7 words that they're using for at least 3 months or more. And then those need to go away for at least 3 months for it to truly be a regression. But regardless, there is this phenomenon within autism where it seems like children are gaining skills, and whether it's a regression or just a plateau, those skills level off. So that's why I have that qualifier there. But this, in any domain, if there's a loss of skills, we get concerned. And then in the area of behavior, if you're seeing anything, obviously any shaking or seizure-like activity that's not responsive to voice or touch, or that would be concerning. In very young children, there's a type of seizure called infantile spasms, which really kind of looks like the child is almost doing like an ab exercise, a crunch repetitively, and it's very brief. And those can be very detrimental to development, and if recognized, quite treatable. So if you see anything like that, that would be something to encourage the parent to seek out further evaluation, or if you are the provider, obviously, to make note of that and reach out to a neurologist. Any unusual movements, and by that I mean something that you would consider atypical or what people may call stimming, kind of atypical finger movements, hand flapping, something that's very, very repetitive, extreme tantrums without an ability to recover. So every 2-year-old is going to have a tantrum, and some are a little more emotional than others, and that's all within the realm of normal. But if it's a child who really cannot recover for a prolonged period of time, and this is occurring over and over again, that would be a reason to refer. Any self-harm, biting, self-aggression, hitting, head banging, and then any aggression toward others, so caregivers or peers. And I was excited to talk to this group because, from my understanding of the audience, some of you all are in a clinical setting, some of you all are providing services in the home, but either way, especially if you're in the home, you really have a unique opportunity to watch for those red flags that we talked about, and to really observe the parent-child interaction, and be on the lookout for parental stress or disengagement or what the parent may be carrying that we don't get to see, maybe automatically in the clinic. And you can also get a sense of the child's media use, and which can definitely not cause developmental delay, but obviously if a child's at risk, we want them to be getting as much face-to-face time with others as possible to promote their development. You can model those interactions. Perhaps parents or caregivers just don't know, or it's their first child, or they haven't had a good example of how to play or how to interact with their child. So you have a really great opportunity there. And then just to listen to parents' concerns, because there may be things that come up that they don't know that they need to tell their provider, or they're maybe not as bold to advocate for their child. And so I think it's a really great opportunity to empower parents because they know their child best. All right. And so when we think about, as we move into that next objective of the medical evaluation, we're first have to think about why this might happen, because that's going to inform our evaluation. So what are potential causes of developmental delay or disability? So there can be prenatal causes. So it is a genetic syndrome, or an inborn error of metabolism, which again is often a genetic condition or something that's kind of there at baseline. Brain malformations, maternal disease during pregnancy, and then other environmental influences. So substance use such as alcohol or drug use, but also there are some medications that are teratogenic and can affect development, or other toxins that the child may be exposed to prenatally. And then there are perinatal factors. So, and this is kind of really the time immediately before and after delivery. So, was the child born premature? That's, of course, going to impact, potentially impact their development over time. And then, or was there a labor and delivery related event? So, any concern about hypoxia or lack of oxygen at birth. And usually, families can identify that by whether or not they got to be with their baby immediately, or the baby had to go to the NICU or be to a separate area. And then there are some postnatal causes, so hypoxic ischemic injuries, such as a near drowning or something that really prevents oxygen to the brain for a prolonged period of time, a traumatic brain injury where there's direct injury to a part of the brain, infections such as meningitis, seizure disorders, like I mentioned, infantile spasms, and severe and chronic social deprivation can actually result in developmental delay. It really has to be pretty significant. So thinking about kind of orphanages where children really are not interacted with that much at all. But that can play a role. That can be a cause. And similarly, severe malnutrition, which thankfully we don't see that as much, where we have access to a lot of food, although not always the most nutritious food. But in some areas where there's severe malnutrition, you can see it affect development. And then different toxic metabolic syndromes or intoxication, such as lead. So lead can be a cause of developmental delay. So what is the appropriate medical evaluation if you're concerned? So step one, like I said, encouraging the family to see the pediatrician if that's kind of your role in the care of the child. And then the pediatrician will do further developmental screening. That's actually happening at every well child visit, but they may do some additional kind of use formal screeners that the parents fill out, and those should be occurring at certain ages anyway. The medical evaluation includes a good physical exam, and then assessing hearing and vision is often very important. Sometimes that can be done in the primary care office. Often that has to be through a referral at this young age. And then labs or imaging will be done on a case-by-case basis, and I'll touch on that. So if a child, if we confirmed that a child does have global developmental delay, kind of our primary piece of the evaluation for all children would be genetic testing. And actually, hot off the press, and just this year, there's a new article in Pediatrics that has kind of moved from used to be chromosomal microarray and Fragile X to now the standard first tier test would be exome sequencing, because we are making such rapid gains in the field of genetics. So that's actually kind of like the best first step for a child who has global developmental delay. Additionally, I noted on here, if a child has very significant motor delay, or the motor area is much more delayed than other areas, we will also think about testing the thyroid, and then also sending muscle enzyme levels. So that's called a CK. That's kind of additional tests we would think about. And then if it's a very significant or isolated language delay, we would also add in audiology. And that's true for global delay as well, because their speech and language is delayed if it's global. So we always want to ensure that the child's hearing is intact. So those are some of our initial referrals. And then these are kind of based on, like I said, case by case basis based on your concern. So if there is concern for seizure, we would want to do an EEG. Here that often involves us referring to neurology, because we have fabulous neurologists at our convenience, but in other areas that may be the primary care doctor ordering that. And then any of those neurologic exam findings we talked about. So that asymmetry, tone, concerns with tone, or any type of odd movements or tremor, we would add on imaging. So that is most commonly an MRI. And then regression. So if a child has regression, we get, like I mentioned, very concerned. And so we may do a variety of things based on the case, but usually EEG, MRI, maybe some more metabolic labs. If they haven't had those done, our newborn screens actually pick up on a lot of concerns for inborn errors, some of the inborn errors of metabolism that are treatable, but there are further tests that can be done. And then, of course, as I mentioned, we're doing genetic testing in all of our children with delay that we're concerned about. And then other important referrals would be to services. So referring to ECI is actually probably the first and primary referral that we need to make for children so they can start getting intervention if it's needed. Parents can also be referred to other outpatient therapies that they may be able to access both through their insurance. Audiology, as I mentioned. Ophthalmology, we will do if there are concerns about fine motor integration or maybe visual tracking or anything on our exam that makes us concerned about the child's vision, or maybe even other risk factors such as prematurity that we get on the history. A referral to developmental behavioral pediatrics, which is what I do. So we'll be able to do a very comprehensive developmental evaluation. And then once you kind of confirm that there is a delay, you would refer to genetics. If you weren't doing that testing on your own, not everyone can counsel and order exome sequencing appropriately, so they may refer to a specialist to do that. And then neurology, if there are those motor or seizure concerns, and some children to physical medicine and rehabilitation. So those are the children where we have significant concerns about their tone and their motor abilities, and we think they may benefit from some mobility aids or other supports. All right, and just a brief slide on what we actually do during the developmental behavioral pediatrics evaluation. So we take a very detailed developmental history, looking at all those prenatal, perinatal, postnatal risk factors, asking about all these milestones and when they actually occurred. And then we do our physical exam, and we use some standardized tool to do direct observation and developmental testing with the child to try to get some concrete information with the child. And all of our evaluations include an assessment for autism and concern for autism in addition to other developmental concerns. And then ideally in 2 hours, which sometimes it's hard to do, but a lot of times we can get a good assessment in that time. But ideally at the end of that, we're giving a diagnosis to the family and some first line recommendations. Okay. I know this is a whirlwind. I'm speeding through, but I want to make sure we have time for our second speaker and then time for questions. But I wanted to wrap up my portion with just a few key resources that I think are important to make families aware of in this age range. So the first is Medicaid waiver programs for children with disabilities. And it's sometimes funny because it feels strange talking about this at such a young age when really only at that point in time, all we may know is that there's a global delay. But as many of you may know from personal experience or working with children and families, these lists are quite long in Texas. So up to 16 years or plus maybe now. So it's important to let families know as early as possible about the opportunity to be on the Medicaid waiver programs, because to sign up, really, they just need to call and get on the list and don't really need to provide documentation or any further information until they become eligible, which could be several years. And so at least they're on the list at that point if there is any concern. And waivers let states use Medicaid funds for long-term home and community-based services for people with disabilities or special health care needs, other chronic conditions as well, in order to help them live in the community. And they can fund things like personal care, respite care, home modifications, and then other things like tailored to the individual. So it's great for families to have. It's really hard when they learn about it, and the child's almost a teenager, because then they have to wait much longer. And once they receive these services, they can go on throughout adulthood. So the second point is a way to learn about how to sign up for these waivers, several of the waivers, and that's through the local intellectual and developmental disability authority. So if a child does have a delay or disability, plugging them in with their local LIDA would be important. So for Harris County, that's the Harris Center. So other counties, you would have to look up what the LIDA is in that area. And then lastly is just for a plug for the Meyer Center, we do have workshops. We have a fabulous team of 5 social workers, 3 of whom are bilingual, and they've organized workshops in English and Spanish for families. And these are free to the community, so you don't have to have been seen here. Other folks pediatricians can refer in their patients who have diagnoses but who may have gotten them elsewhere. So anyone can access these workshops. Slide's probably a little small for you all, but the way to do so would be on our website, or you can email swprograms, social work programs at texaschildrens.org. But I would say probably the most helpful for many families is kind of a new developmental diagnosis roadmap workshop. So they provide a 2-hour it may even be longer than that, actually, workshop where they walk through what does it mean to have a developmental diagnosis. So something like developmental delay, intellectual disability or autism, and kind of, what do we think about, and then what are the next steps in terms of community resources. So and then there's different workshops at different ages and stages. We also have a workshop for folks that are on our wait list to prepare them for what to expect when they come here. And every now and then workshops about parenting and behavior, like how to support your child's behavior. So all that to say, there's a lot that is provided longitudinally for our families, and it's for anyone. So not just folks who've been seen here. All right, and these are the references for my portion of the talk, my email address, and I will stop there because I know we have our next speaker.
Thank you so much, Dr. Harris.
Hi, y'all.
Laura.
I have to load my PowerPoint another way because it's not where we hoped it would be. So give me just a minute.
I'll have to figure out how to stop sharing, so you're fine.
Oh, okay, great, good.
Let me figure. Okay, here we go.
Maybe that's why I couldn't find it. I don't know.
There. See now, I stopped sharing. See if it works.
Oh, there it is. Okay, yay. Do I need to put it in a presentation mode, or is this how it is, Gladys?
It's already in presentation mode, so you should be good.
I don't have to do anything then. Okay, great. I love that. Hi, my name is Laura Buckner, and I was really appreciative of Holly's wisdom and great information. I know infantile spasms really well because my son presented with them at the age of 3 months. And back then, he turned 36 on the 4th of July. So 36 years ago, they didn't have a lot of treatments for infantile spasms. I'm really happy to say things have gotten so much better because there are treatments for that kind of seizure. But he presented with those at the age of 3 months. And we were given, he has a rare genetic disease, and we were given a pretty grim prognosis, but I'm happy to say that he has defied a lot of that. He's at work today. He works part-time at the Habitat for Humanity Restore. So let me talk to you a little bit about how do you move forward? Because once you get a diagnosis like this, or, a recognition that there's a developmental delay, it's a little overwhelming, isn't it? And you have to go home and live a life. So I really encourage you to start paying attention and writing down what you see, what you observe, what are your questions, because when you get in the doctor's office, they're just like Holly did just a minute ago, you're getting a lot of information at one time. You have the emotional response going with all of that, and you don't always remember what was said, and you sure don't always remember what your questions were or what your observations were. So, think about what your child's developmental or behavioral concerns are from your perspective as a parent, or if somebody is in the home. What are those observations? Because taking your observations into that doctor's office can really help guide them in their work. But at the same time, I want to really encourage you to recognize, so the geneticist or the genetic counselor, the pediatrician, the developmental pediatricians, all of those people are so critical in this work. But their job is to make a diagnosis and to inform the family of everything that is possible with this diagnosis. They can't present you with a rose-colored glasses perspective, because it may not be a rose-colored glasses in the future. So their job is to paint the worst possible scenario so that you know what's possible. At the same time, none of those professionals have a crystal ball. Like I said, my son was given a very grim prognosis, and we deal with significant developmental and intellectual disability, but not near what was projected 36 years ago. So your job, the family's job, and this is what professionals, you can encourage the family to recognize that their job is to become an expert on who this child is outside of the diagnosis, to have hope for this child and for their future, to believe in what's possible for their child. You know, you don't know what the future holds when you've got a 3-month-old baby. Who knew 36 years ago that technology would be what it is today? We didn't have the internet 36 years ago. We don't know what the future holds and what potential there is for our kids. So we've got to have hope and believe in their future and give every opportunity for what's possible. So I gave you this form as one way of documenting your own or a parent's observation log and observations in terms of their developmental concerns. You know, when did you start noticing that your child wasn't talking like other kids his age or her age are doing? When did you notice that my child's not walking and all the other kids at the daycare are? When did you start noticing that? Because it gives that developmental pediatrician or geneticist a timeline, give a sense for how long has this been going on. What are you noticing? You can write down your own questions about it as well and take this form into the doctor's office so you don't have to try and remember it all. You want to really develop partnerships with your pediatrician, your developmental pediatrician, your geneticist, genetic counselor, because they're your experts. They're the ones who know. But I will also say that from my own experience and working with a lot of families, some of the best experts are people who are on a similar journey as you. So if you can find an organization that deals with your child's genetic condition, for example, they're going to know stuff and they're going to have connections with other people who have the same diagnosis. They're going to know stuff that you won't necessarily get in that quick medical appointment that you're trying to set up. So connect with family-oriented organizations, and I'll talk a little bit more about that in a minute. Another observation log you could use, and I mean, this is nothing fancy. It's just, 5 columns, 6 columns, and some rows. You could do this on a sheet of paper in pencil. But what are your behavioral concerns? When did you start noticing that maybe he's doing things different than other kids his age? My son had his first infantile spasm on the living room couch on a Sunday afternoon. And I called the pediatrician. And I still have to laugh about this, but it wasn't funny at the time. He told me to bang a loud pot and see if I could startle him out of it. He had another infantile spasm the very next day, and we were in the pediatrician's office within an hour. And referred, actually, he had an infantile spasm in the pediatrician's office with 2 pediatricians looking at him. And they didn't know what it was. They sent us to a neurologist, thank you God, but they told me they thought it was reflux. Infantile spasms are hard to recognize. So when did you start noticing that funny little, like he's doing a crunch? Because it's very brief, it's very quick. When did you start noticing that your child just couldn't stand the tag in the back of her clothes? And would take her shirt off if it had tag in the back? Or when did you start noticing that she seems more aggressive or he seems more aggressive than most kids his age? Write those things down. Take them with you to the medical appointments. And recognize everybody here involved, the parents, the grandparents, the siblings, the friends. Everybody's going to need some emotional support. Diagnosis of a developmental disability and or genetic condition is overwhelming. And not everybody you know has had that experience. So you'll find that a lot of people can't relate because they've never been to a geneticist, don't know anything about developmental delay. And that's where you have to really seek out people who are on the same journey that you're on, because they're going to need emotional support, and so are you. So a good way to get some of that emotional support, and this was our experience. We had a son with a rare genetic disease nobody ever heard of before, including myself. As he grew and developed. His development was significantly delayed. And nobody really understood some of the behavior that we saw. And so a good thing you can do is help loved one understand the diagnosis so that they know this is not just bad parenting, because unfortunately, that's what often happens to families in this situation, especially if there's a behavioral concern. People are very quick to make judgments that this is just poor parenting. And if you help your family and other people understand what is the diagnosis and what's likely to be a part of that diagnosis, behavioral concerns are a part of my son's diagnosis. It helps them to understand this isn't bad parenting. I can remember my dad saying, that kid just needs a good spanking. And if that would have worked, we wouldn't have had the behavioral concerns. We had tried everything. So helping people understand that this isn't poor parenting, this isn't him just being out of control and him just being an obstinate or spoiled child. There are other things at play. Helping them understand that can really provide the family with some emotional support, because then people have a better understanding of what's going on. Support the family in building a care team, and I'll talk about that in a minute. Absolutely, you want to refer those families to the school system for ECI services, the local authority, the LIDA for ECI, early childhood intervention. But as soon as they turn 3, they no longer qualify for ECI, and then they do qualify if there's a developmental delay significant enough. They qualify for services from the local school district, and you can refer people to them. Connect them with family support systems. I highly recommend Texas Parent to Parent. I always recommended Family to Family Network, but I'm sorry to say that they are shutting down operations at the end of this month. So it's a lack of funding. So don't send them to Family Network. I think their website and their resources are going to be available for a while, but they won't be able to answer phone calls or work on the internet with families like they used to. Texas Parent to Parent is still very much a viable resource. The Partners Resource Network is a very viable resource. Look for financial or legal supports available if the families need them. Medicaid is certainly one of those, but Medicaid has its stipulations for how you qualify, and so you have to check with the family about how they might qualify. You definitely want to use a child-centered, person-centered approach to families. In years past, we used a very much a medical model approach, where it was all about what was wrong with the child, what could never be cured, what couldn't be fixed, and that can be downright depressing. Instead, we want to help families look for who is this child outside of the diagnosis. What is their love? What do they love to do? What kind of people do they like to be around? What kind of activities do they enjoy? Because those are the things that will lead to a real life. We talked briefly about early childhood intervention. We call it ECI. It is a statewide program funded under the Texas Health and Human Services Commission for kids from birth to 36 months of age. And to qualify, you have to have a certain diagnosis, a certain medical diagnosis, or a significant risk of developmental delay or certain risk of disability. ECI was on my front porch probably 2 weeks after my son was diagnosed, and they were invaluable resource. There's a link on this slide that shows you where you can go for a qualifying diagnosis search in case you're wondering, would this diagnosis qualify for ECI? A diagnosis is not needed for a referral, however. You can make a referral. Anybody can make a referral. If there's any suspicion of a delay, even if you're still waiting for the appointment with the developmental pediatrician or the geneticist, if you're concerned about a delay, you can make a referral and they will come and evaluate, even as early as birth. But I really encourage people to recognize that this child is so much more than the medical diagnosis. I want people to think of the medical diagnosis as a passport to services. Unfortunately, and I did it too, you get so involved with the medical professionals and the therapy professionals and the educational professionals, and they're all focused on the diagnosis, that you can become hyper-focused on the diagnosis and lose sight of who your child is beside the diagnosis. So think of the medical diagnosis as a passport to services. There are certain times you need a passport, right? Like if you wanted to leave the country and get back in, you got to have a passport. I live an hour from the state line to Shreveport, Louisiana. I do not need my passport to go. I was there this morning for an eye appointment. I don't need my passport to go to Shreveport across the state line. You do need your passport, your medical diagnosis, to open the door to, for example, early childhood intervention services or special education services later, or certain medical professionals appointments, or Social Security. Those kinds of things, you will need your passport for services. But if you're not trying to open a door to services, put your passport in your back pocket, because the diagnosis is not the sum of who this child is. This was the family care team that I mentioned, and this was done by a mom out in California years ago, but I thought it was so brilliant that I like to share it. I share it with her permission. This is her child's care support, and you see she has it organized by colors. Some of them are medical supports. The blue is medical. The green at the bottom right is friends, neighbors, support groups. The blue-green up at the top right are information and advocacy efforts. So you can see how you could help a family sort of develop a support map. It gives them a better sense of who they could call on for what. Because again, you're overwhelmed with this diagnosis. Unfortunately, often when there's a child with a diagnosis and demonstrating pretty significant developmental delay, families find themselves very isolated because people don't know how to be with them. They feel sorry for them. They're embarrassed that their child's developing so much better than this parent's child. And so families often find themselves pretty isolated, and that's not a good thing. That's not helpful in terms of mental health. So help families develop a care map that helps them think about who they could go to for what, and that they do have people in their corner, even if some of the friends they thought they had have sort of dropped off the map. I'm so glad that Holly mentioned the Medicaid waivers, because you have to get them on the list. I tell families before the baby's born, as soon as this baby's born, you got to call this number and get them on a Medicaid waiver list. Every state in the country has Medicaid waivers, but unfortunately, Texas we are at the bottom of the list in terms of how we support children and adults with disabilities. So the Medicaid waiver wait list is typically 12 to 18 years. I put my son's name on a list when he was 14 years old, and he came off the list at 32. So I have a link in this slide that I encourage people to check out. It's a link to a website called Navigate Life Texas. It's a brilliant website, but this link that I have linked here takes you specifically to the Medicaid waiver list, and it's in terms of parent-friendly information. If you go to Health and Human Services, no offense to them, but some of their stuff is overwhelming to a brand new parent who's just gotten a diagnosis and has no clue what they're talking about. This website has a video and a parent explaining all the Medicaid waiver information in very parent-friendly terms and language. And then that website will also provide phone numbers, websites, where to go to get your child on that list. And I encourage people who are working with families to help them get on the list. Know that just to add your name to the list, or this child's name to the list, you don't have to qualify to get the services. You don't even have to know what the child's going to need. When my son was 3 months old, we had no idea what my son was going to need. You don't want to wait, like Holly said, you don't want to wait till the child's 15 and realize he's going to need more support than you can provide, and then have an 18-year wait list. You don't want that. So this shows you the information that will be requested: date of birth, social security number, demographic information, and a very brief healthcare questionnaire. I do tell families, you're going to get an ID number. Keep very close track of that. And if you change any contact information, your address, your phone number, your email address, let Health and Human Services know, the local authority know, because if your name comes off that list and they can't find you, your name comes off the list. They're not going to look for you. These are some helpful phone numbers that you can use, and you'll find these on the Navigate Life Texas website as well. And so I tell professionals working with families, do give families this information in writing. Don't just tell them while you're sitting down in a meeting with them or on the phone, because it's going to go right over their heads and they're already overwhelmed with a whole lot of other information they're trying to grasp. Do give it to them in writing, and do suggest that somebody else make the call for them or with them, because again, they're overwhelmed. It's a lot to think about. They have no clue what a Medicaid waiver is. And you don't want this to get lost in the midst of everything else. So I tell professionals, make the call with them. It doesn't take 10 minutes. Make the call with them, and then remind them to update their information. Once your name is at the top of the list, you have two options for completing the Medicaid application. It's either a paper form, or there's a website called yourtexasbenefits.com. Families don't need to worry about that for a long time, because they're going to wait for a while to get off the list, but you can explain this to them. That's how it happens. And lastly, I just want to encourage you to cultivate hope with families. Like I said, getting my son's diagnosis at the age of 3 months with a very grim prognosis was life-changing. I'll never forget it. But I'll also never forget the words that our pediatric neurologist told us the night he diagnosed our son. He said, "This child will be as disabled as you see him." That put a lot of responsibility on mine and my husband's shoulders. We had to see who our son was outside of the diagnosis. If all we saw was disability, he was going to be pretty darn disabled. If what we looked for and what we saw was constantly, what is he good at? What does he love to do? Where does he love to go? Who does he love to be around? What can he do well? What can we help him do better? That's how you cultivate hope. Because this child will be as disabled as you choose to see him. Powerful, powerful words that were life-changing for us and for our son. I'll close with this. That's my email address. If you have a question that we're not able to answer on this webinar today, you're welcome to email me later. But we have about 8 minutes, so I want to open it to questions that we may have. Thanks.
Thanks, Laura. It does look like we have one question in the Q&A box. So if you do have a question, feel free to click on Q&A on the top of your screen and enter that question. And so the first one is, do children without developmental delay with a rare genetic condition qualify for Medicaid waiver?
That's a good question, and it will depend on the diagnosis. I think it depends. It depends on the diagnosis, and it depends on the Medicaid waiver. Some Medicaid waivers are specific to medical conditions, and not necessarily a developmental delay. Others, the one my son is on, is clearly about intellectual disability. You know, that's the other thing you learn as a family member. You learn to pull out which passport you need for what service. So my son was on a Medicaid waiver when he came up on the first Medicaid waiver when he was 4 years old, and we just got darn lucky that they opened that Medicaid waiver in our county, and I was one of the first on the Medicaid HHSC doorstep. And he qualified for that particular Medicaid waiver by a genetic condition and some developmental delay. He would not have qualified for that waiver if he was diagnosed with an intellectual disability. The waiver he's on now requires an intellectual disability, an intellectual diagnosis. So depends on the waiver and what services you're trying to qualify for. If you go to that Navigate Life Texas website that I referred to in the PowerPoint, they will explain the Medicaid waivers, and there's a list of them, and they'll explain what qualifies you for what waiver, what type, this waiver's for this waiver's for that. There's about 7, maybe, don't quote me on that, but we have a number of waivers. It just depends on what the services you need are and what the child's diagnosis is to qualify for those services. I hope I've answered that.
Yeah, absolutely agree. I have nothing to add.
I was glad you mentioned it, Holly, because it's, I hear from people all the time who they'll email or they'll call and say, well, I've got a child's about to graduate high school, and we don't know what to do after that. And I'll say, so are you on the Medicaid waiver list? And what is that?
Yeah.
Oh my God, my heart just sinks. Now I will tell you, the state doesn't call it a wait list. The state calls it an interest list. People are interested in services. But those of us out in the field and those of us helping other families, we call it a wait list because it's a long wait. Yeah. Other questions? Laura, your experience in presentation, I was reading something, but I couldn't read it all. It came up. Or was it in chat? Oh, here it is.
It says your experience and presentation are always amazing. Thank you.
Oh,
That was a compliment.
You're very kind. I've learned a lot the hard way. I said to my husband one time several years ago, we're so lucky that our son has done as well as he has with this genetic condition, because not everybody does as well. And my husband said, Laura, there was no luck about it. We've worked our asses off. And he's right. We have. We still are.
I'll just say too that some of the places you reference, I mean, there's a lot of wonderful agencies, but I know our social work team loves the, Texas Parent to Parent, Partners Resource Network.
Yeah.
Everything you listed is really great for families to get plugged into as soon as possible.
But in addition to that, I really encourage families, if there's a specific diagnosis, unless it's like, my son's is rare, but there are like really, really rare that don't have organizations. But a lot of these rare diagnoses will have an organization, a national or my son's is international organization, that they have a website, they can connect you with other people. I was in DC in February for what they call the March on the Hill, where we talked to legislators about medical research funding. But you meet other people who they maybe not share the diagnosis themselves, or they might share the diagnosis themselves, or they have a child with a diagnosis, and they're going to know stuff that the professionals just aren't going to know. No offense. But when you live with it, you learn stuff that is really helpful to other families who are on the road behind you. My son's is tuberous sclerosis, Holly, in case you didn't figure it out.
Yeah.
Yeah. Sort of a cousin to Fragile X.
Yeah, absolutely.
Yeah.
Well, it doesn't seem to have any more questions. So at this time, we'll conclude the webinar. So thank you very much. Once again, we're grateful for your time and for everybody's participation in today's webinar. If you are viewing live today, within 24 hours, you will receive an email with survey links for both social work and nursing evaluations. And this needs to be completed to receive credit. Once the survey is completed, you will receive your certificate of completion within 48 and 72 business hours. If you're viewing a recorded version of this webinar, this session is not eligible to receive CEUs from the recording. If you have any questions about this session, please feel free to contact me, Gladys Pryor, at gladys.pryor@bcm.edu.
Hey, Gladys, I've got a question real quick. I'm sorry to interrupt. The PowerPoint, since it had links in it, do they have access to that after we close today, or how's that work?
Yes, I will send the PowerPoints in the email.
Thank you.
Our next webinar in this series is titled Red Flags of Genetics and will be presented by Certified Genetic Counselor Amanda Gerard with Baylor College of Medicine and Texas Children's Hospital, and Laura Buckner, who is our second presenter today. This session is scheduled for Wednesday, July 30th at noon. A registration link for this upcoming webinar will also be included in the same email containing the information about the survey, and we hope you can join us in the future. Once again, thank you very much for your time, and this concludes today's webinar. Have a great afternoon.
Thanks.